So good evening, everyone. It's my pleasure to welcome you to our program and thank you for your interest. I'll be introducing tonight's featured speakers and moderating the question and answer period. But before I turn things over to the speakers, let me introduce myself and provide some brief background about this educational series. My name is David Wofsy. I've been a faculty member in the rheumatology division at UCSF for 40 years. For the past 6 years, I've served as director of the Russell Engelman Board, which consists of dedicated volunteers who help to support rheumatology research and education at UCSF. This year, the board and the rheumatology faculty made a commitment to provide free informational programs for patients with rheumatologic diseases, their families and friends, as well as many others who support our work. Our first program was in May, and it focused on the impact of COVID-19 on patients with rheumatologic and immunologic diseases. Today, we take on the most common rheumatologic disease, osteoarthritis. Future programs are going to focus on other diseases such as rheumatoid arthritis, juvenile arthritis, lupus, to name just a few, or on topics of broad interest such as diet, for example, or the impact of chronic illness on families. Tonight's session is entitled Osteoarthritis, Current Treatment and What's Ahead for the Future. The speakers will be Krishna Shaganti and Thomas Link. Dr. Shaganti is an associate professor of medicine. She heads the clinical program in osteoarthritis for the UCSF Division of Rheumatology and provides her expertise in skeletal health at the Orthopedic Institute as well. Dr. Link is Chief of Musculoskeletal Imaging for the Department of Radiology and Biomedical Imaging and Clinical Director of the Musculoskeletal and Quantitative Imaging Research Group. Both speakers have extensive experience with osteoarthritis and are recognized nationally as leaders in the field. During the presentation, I encourage you to submit questions via the question and answer function on your screen. We will try to get to as many as we can, hopefully all of them, during the last 20 minutes or so. Please do not try to use the chat function, which I believe is going to be disabled for this program. So use the question and answer function. The program is being recorded, but only the speakers and I will be seen or identified. Now I'll ask Dr. Shaganti to share her screen and get us started. Dr. Shaganti.
Thank you so much, David. Thank you for the opportunity to be here and to speak on this topic. And I look forward to your questions at the end. So I'm going to talk about osteoarthritis, or OA, present and future. And I'll outline a little bit what we want to get through with this talk. I'm going to spend some time just briefly talking about the pathogenesis of OA and the current treatment recommendations as outlined by the American College of Rheumatology. And then I want to actually spend some of the talk, at least half of it, talking about regenerative medicine or cell-based therapies, where we are with these potential therapies and what kinds of things are being done to try to hone and add more rigor to the way that these are being used and developed, and where the challenges lie in being able to use these. And I hope this will generate some discussion and questions, because I know it's an area of great clinical interest given how many people are affected by osteoarthritis. So just as a beginning, it's important to think about osteoarthritis, especially what we call primary osteoarthritis, which means osteoarthritis that's not secondary to some inflammatory process like rheumatoid arthritis, but happens on its quote unquote own, as being multifactorial. There are these primary causes, perhaps even at early stages, some aberrant biomechanics, such as an ACL injury or tear, change in cartilage components with age, and perhaps other metabolic issues that are systemic that may contribute to the onset of this condition, that then leads to these secondary mediators within osteoarthritis that are hallmarks of inflammation within the joint and other changes that may or may not be targets of therapy in the future. The final stages are what we look at on an X-ray, where we see real signs of tissue damage. Patients feel pain sensitization, and we see even MRI features, which I'm sure Dr. Link can speak more to in his talk. For the pathogenesis of OA, it's important to think about how all features of the joint and aspects of the joint are really involved in the pathogenesis of this illness. The soft tissue structures play as much a role as the cartilage, where once it was thought to be only cartilage loss that drove this disease. It's very clear that all of the structures in the joint play an adaptive role, sometimes maladaptive, in the progression of osteoarthritis. So this is a slide illustrating sort of nice, normal, healthy cartilage with subchondral bone seen here. And this is more macerated osteoarthritic cartilage after some mechanical wear and tear, where you can see that the cartilage is rough and the subchondral bone has tried to kind of thicken as a response to this extra biomechanical stress. And we see that on x-rays too. When we see osteophytes or bone spurs forming, we see that the bone is really a dynamic tissue. We see here something called buttressing, which is where cortical layers of the bone increase in thickness in response to stress, which is being felt in this hip joint up at the top. On MRI, we see mechanical stress in the form of bone marrow lesions, which I won't spend a lot of time on because Thomas is much more of an expert here. But these are hyperintense marrow signals in these particularly fluid sensitive fat suppressed images. And they represent different histopathologic changes, including thickening of that subchondral plate that I showed you, microfractures, bone marrow edema, and even sometimes necrosis. Clinically, they've been associated with real clinical problems, including the increased risk of cartilage loss and OA progression, as well as pain. There's also a real role for synovitis, which is something that we think of much more as a hallmark of autoimmune arthritis, like rheumatoid arthritis. But within subtypes of osteoarthritis, there's also enough to suggest that there's synovitis playing a role, and these may be subgroups of osteoarthritis, potential targets for other types of treatment in the future. These are the ACR recommendations and sort of deciding sorts of decisions on how to treat patients based on evidence-based evaluation. And these are the non-pharmacologic recommendations. So they strongly recommend exercise, a program of self-management, often web-based, some of these other features here, and conditionally recommend some of these other modalities because the evidence is there, but not as strong. Much of what's considered important from a non-pharmacologic treatment perspective is adjustment of biomechanics, especially of the knee when there's medial knee osteoarthritis or varus mechanical biomechanical derangement. Much of what we try to do is get that malalignment back to being nice and straight and normal, so the weight is distributed evenly over the joint. That's where most of the kinds of things that we use come into play, and these are things that have been around forever. They're not very glamorous, but things like wedges and unloader braces, certain types of shoes and canes, all of these are meant to shift the weight-bearing axis towards the center of the affected varus knee, towards neutral alignment. And again, it's important to bear in mind that these are therapies that are directed against a knee that already has moderate to severe osteoarthritis. So we're already in a situation where the problem is there and we're trying to alleviate or temporize some of the impact of that problem. Pharmacologic therapies are relatively limited for this quite prevalent condition, mostly centered around anti-inflammatories and intra-articular steroids. Interestingly, there are things that are less strongly recommended, again, based on evidence. And there are many things that have been tried. As you can see, people are sort of looking for this holy grail, so to speak, of osteoarthritis treatment. And many things have been looked at and are strongly not recommended by the American College of Rheumatology, mostly through lack of evidence or negative trials. Conditionally, also, there are some other treatments that are commonly used, but are not at a high level of evidence to support their use. And we can talk about these certainly at the end. And so the basic take-home message in terms of the recommendations that are current are that really the mainstay is to do a combination of pharmacologic and non-pharmacologic therapies in these conditions. And that seems to be the thing that helps patients the most. Exercise, while patients may be limited in their functional capacity, seems to have a real impact on central pain pathways in addition to functionality of the joint. And improvement in pain has been shown with regular, gentle sessions of exercise, despite any force of biomechanical change that's recognized in the joint. So independent of whatever change of loading is seen in a knee joint, for example, there seems to be a benefit in pain improvement with a regular exercise program. So it's really important for patients to remember that anything in terms of motion does help. Okay, so now I'm going to talk about regenerative medicine a little bit. And this is really, and there are many other types of therapies I could talk about before I go into this. I'm not, because of time, talking about in depth about herbal remedies or prolotherapy or intra-articular non-corticosteroid types of treatments, but I'm happy to talk about it at the end. I tried to focus a little bit on stem cells, or this idea of regenerative medicine using stem cells. And that's a general term. The source of the cells can be variable, and that's part of what we'll talk about. Platelet-rich plasma is also included in regenerative medicine, and we can talk about that also at the end. Just want to sort of state that there really is wide variation in the methodology of these types of therapies, and thus far there haven't been large, standardized, randomized clinical trials to support their widespread use. But having said that, they are being used fairly widely because there's been a strong push in marketing that has somewhat outpaced the rigor of studying the effectiveness and methodologies of these treatments. So stem cell therapy is really a form of precision medicine in a way. What we want is to really create a pure functional cell line that has a predictable clinical performance and quality. And it's a really interesting field. I think it has an enormous amount of promise, but there's a lot to sort out. There's so many steps to this. So it kind of is a bench to bedside field in progress in my mind. And really part of it starts even just from what cells to use, what's the source of those cells, how are we going to process those cells to create a reliable composition with specific biological attributes that are reproducible, and how do we measure the clinical performance of those cells? And so it's really, it's fascinating, and it's a field that's growing by the year. We want measurable outcomes, of course. So what do we want with these? Do we want to just simply control symptoms, or even better, can we stop or reverse OA progression with their use? And I want to just point out, before I go to the next slide, I talked a lot about how multiple components of the joint are so important, but so much of regenerative therapy does go back to focusing on cartilage regeneration and chondrocytes. So that's kind of the background for some of this. So what are stem cells? So this is a nice illustration from the NIH website that looks at really where these cells are coming from. And I want to point out that there's so many different kinds of cells here. So when you're quote unquote harvesting cells that are stromal cells, you're getting an admixture of different kinds of cells. The real target we want is these MSCs, or mesenchymal stem cells, which are the ones that really go on to form the connective tissue in joints, especially bone and cartilage. But you have a lot of other things in here that are really kind of pluripotential, unless there are ways to really sort them and direct them in a certain direction of development. So what's the source? Is it going to be stromal, as we saw in that previous picture from the marrow itself, or adipose cells? There, like we pointed out in the last picture, there's a lot of heterogeneity in them. And then how do you process them after you take them out of there? There needs to be standardized automated measurements of the ways in which we know that the cells are what they are purportedly supposed to be and do what they're supposed to do. And I won't get into all the basic science of it. I'm not the person to talk about that, but there are good people working on this. And I acknowledge them at the end, but there's a very nice series through the Arthritis Foundation looking at OA clinical research that's head by George Mushel at Cleveland Clinic, and Scott Rodeo at HSS. So some of these ideas and sort of their thought leadership kinds of questions are coming from that group, which is also affiliated with the Arthritis Foundation. This is a paper I wanted to just point out, which actually looked in a rigorous way at all the studies that have been published in stem cells, looked at the quality of the evidence within these papers, and found that only 5 out of the many double numbers papers that have been published reached a level 1, which was sort of a version of a randomized controlled trial. The numbers are still very small, but I just want to point out how young this field really is and how little we really know. And even in these studies that reached a high level design quality, the way in which the kinds of cells they used and the way in which they treated the cells were all variable. So even though these are good studies, these are not apples to apples comparisons by any means. And they even had different control groups. Some were placebo, some used hyaluronic acid. So we just can't really generalize from these studies. One good thing that seemed to come out of all of these is there seem to be few adverse effects that have been reported. And then this is a very busy slide. This is some of the results from those papers. I just wanted to point out that, again, this is encouraging and interesting, worth studying, because some of them did find a difference in some of the patient-reported outcomes, at least compared to placebo in those level 1 studies. But again, the numbers are relatively small, and there's still a lot of work to do. So rigor is really what we need here, and that may be coming. There's a couple of papers I'm going to talk about that are from this group. This first one I won't spend a lot of time on, but basically this is going at the bench level to try to find the most elegant way to differentiate the kinds of cells that you want into true chondroprogenitor or precursor chondrocyte or cartilage forming cells. So there are people working on this. I really am hopeful that we will have progress in this, but we're not quite there yet. And this is another paper, again, sort of highlighting how interesting and promising these things could be if done rigorously. This is a rat model of a traumatic joint where they really tried to be rigorous in the way that they targeted mesenchymal stem cells from a cell line. So this is not from a person that was harvested or animal that was harvested. And they created these pellet cultures. That's important because one of the things that's been a barrier to this kind of successful cartilage regeneration has been having some sort of scaffolding on which to put cells that are supposed to grow back cartilage. And this works without scaffolding. So it's an interesting model in that way. And then they actually treated them with BMP and another molecule called Wnt, and found that they really did create more uniform types of chondrocytes. They then looked at the joints and people who had been treated versus untreated and did find a nice improvement in the histopathology showing cartilage, and then confirmed that by doing CTX sort of biomarker staining in some of these animal models. So that's very promising and interesting. It's in a rat model, unfortunately, but it sort of highlights how interesting and sort of tantalizing this field is, but there's still a lot of work to do. So we really need standardized outcome measures for these. Even before that, we need to have a standardized methodology for where we're going to get these cells, how are we going to treat them, those issues that I mentioned before. We have to make sure we're aware of any potential safety issues that come up. And the comparison to groups like a placebo or a recognized control group, hyaluronic acid is somewhat controversial as a control group, is also really important. So we really do need randomized controlled trials. And as some of you may know and realize, to do these cell-based therapies is very intensive and laborious. So it's a bit of a barrier in terms of designing trials that are large enough to answer some of the questions that we want to answer. And comes up in terms of just some practical usage in the clinic. Who are these going to be used for? Are these people with mild arthritis, medium, severe? Who's this going to be ideally used in? And because of all these issues and logistical questions, the group that I mentioned before has sort of, Arnold Kaplan, who's done a lot of work with mesenchymal stem cells, sort of brings up this question of creating some sort of national registry for these, the way that they do for bone marrow transplants, to see if there's a way we can track what's being used in which patients and how successful standardized outcomes are. So that's actually most of what I have. I want to leave enough time for questions, but I really want to thank the Russell Engelman Rheumatology Research Center, especially David Wofsy and Patricia Handeland. And I did want to bring your attention to this if you're interested in this topic, there's a nice OACS forum series that's sponsored or co-sponsored by the Arthritis Foundation, headed by these folks, and also looks in greater detail at some of the science and questions in this field. So thanks so much for listening. I will stop sharing my screen and turn it over to Dr. Thomas Link now.
And let me just interrupt as we're moving to Thomas. Since people have obviously joined since we started, again, I wanted to call your attention to the question and answer function. It's on the bottom of the screen for most of you. It's Q&A. That's how you should pose questions. And when Dr. Link is finished, we'll be transmitting those questions to the speakers and having a discussion session. So please feel free to ask any questions, whether general, scientific, or very personal. And now back to Thomas.
Okay, thank you. I'll just share my screen. Thanks so much, David, for inviting us to this presentation. I think it's a wonderful opportunity to share the knowledge we have and to discuss what we have currently at this stage. So I hope, can you see my screen correctly? Okay.
Yes.
So hopefully, thanks, Krishna. So what I'm going to talk about for the next 15 minutes or so is the imaging of osteoarthritis. And what I want to share with you is some of the imaging techniques that we're using in clinical practice and some of the newer techniques. And I want to share with you some of the lessons we've learned as we have done research in this field for a really long time and specifically looked at prevention, how osteoarthritis can be prevented. I have no disclosures. So as Krishna has already pointed out, osteoarthritis is the most frequent joint disease. And in the US, we have about 27 million people who suffer from symptomatic osteoarthritis. And it affects approximately 50% of patients who are older than 50 years. So this is an enormous percentage. And as you can imagine, this is very important for older people because it results in long-term disability and it poses an enormous burden on the economical health system. And this graph I really like because it shows us how important osteoarthritis and diseases of the musculoskeletal system are, because they are really these most frequent sources of disability in middle-aged and older patients. And this image of a patient shown on the right side nicely illustrates really how painful osteoarthritis is, and every single step is painful, and getting up is very, very painful. So this is not only is it affecting the mobility, but it also affects very much the psychology and the well-being of patients. They have pain all the time, and it makes patients very dysphoric. And this is a radiograph which illustrates severe osteoarthritis. So my talk is structured into 3 parts. I'm going to talk about the radiographic diagnosis of osteoarthritis first. Then we're going to talk about MRI imaging. And finally, we're going to discuss what can be done and what kind of prevention can be done in order to really make sure that cartilage is not destroyed and cartilage is preserved. This is a radiograph, a normal knee radiograph illustrating normal findings. This is normal anatomy, normal. There are no abnormalities here. The joint space is maintained. There are no morphological deformities. However, as the degenerative process starts, patients will develop in the initial phase focal bone spurs, or so-called osteophytes. So once these develop, then we're talking about mild osteoarthritis. This is how the radiograph looks like, and I think you can nicely appreciate these focal bone spurs at the edges of the radiograph, illustrating these early degenerative changes. At this stage, the joint space is still maintained and probably the cartilage is still in a fairly good condition. As the disease progresses, the joint space gets more narrow and cartilage is lost and the menisci are destroyed. This is illustrated in this radiograph, where you see that on the medial side of that joint, you see that there's narrowing of that joint space, and you also see these big osteophytes here. So this is not early disease anymore. This is now moderate, more advanced osteoarthritis that is likely already causing some functional problems. And then as the disease progresses more, you see that their joint space is getting more and more narrow. And eventually it's really bone on bone. And while cartilage is not innervated and not generally a painful tissue, if bone is articulating with bone, this is highly painful. And you can imagine, like this patient I just showed you, if a patient really steps on that knee, then you have really severe pain because this is innervated and this is highly painful. Okay, let's move on and talk about magnetic resonance imaging and what additional information it provides. Now, this is one of these MR scanners. If you have your knee scanned, you're going to be in this scanner partially. The head and the upper body will not be in the scanner. It will only be the lower extremities. So no people who tend to be claustrophobic will not have to be worried when the knee is scanned. Now, the images we get out of the MR scanner are shown here, and you can really beautifully see how this is, how there is significant, beautiful depiction of the ligaments, of the meniscus, of the cartilage, the bone marrow. You see the alignment of the joint very nicely. So we see a lot of tissues directly, which we do not see with standard radiographs. So this is really providing significant information beyond what we see with standard radiographs. And let me just illustrate these findings a little bit better. Here you have a normal knee MRI. This is a coronal plane. You see the femur bone, the tibial bone here. You see the little menisci here, and then this gray area, this is the cartilage. So you have the bone here, and then this gray area, which is the cartilage, also shown in green here. So this is very important really for maintaining the function of the knee, that it glides so easily, that it lubricates. And this is all the function of the cartilage. And it's critically important for the function of the knee. Here you see what happens when the cartilage is slowly degenerating, while you have an intact structure on the left with nice collagen, nice chondrocytes, and intact subchondral bone. As the knee degenerates, you see that there's significant focal cartilage defects and the cartilage gets destroyed. The early changes are quite nicely shown on the MRI. Please keep in mind, and this is really important, that this cartilage loss is not growing back. The cartilage loss is irreversible. It does not come back. It does not grow back. It's not like bone. When you have a bone fracture, that it heals. When you have a cartilage defect or cartilage loss, this does not grow back under normal circumstances. And this is, Krishna has nicely illustrated why there's so much effort on stem cells, because the stem cells ideally would like to regenerate this cartilage, because it does not come back. Once it's gone, and there's nothing you really can do about it. This is an example where you have beautiful cartilage on the left side, beautiful meniscus, but on the right side, you see that with advanced osteoarthritis, the cartilage, this gray area, which we had here, this is now completely gone. There's no gray substance, no cartilage anymore, and the meniscus is also really destroyed. And this is illustrating again how the advanced degenerative changes not only affect the cartilage, but they also affect the menisci. The menisci are these cushions which basically make sure that your joint is correctly biomechanically loaded. And if that meniscus is gone, there's no correct loading anymore. It's really, it makes the bone articulate very differently, and not infrequently patients actually also suffer from fractures because this cushion, this meniscus, does not protect the bone anymore from biomechanical loading. And this is an osteoarthritis also, and that's what David nicely pointed out in his introduction, that it's not always a disease of the older folks. It also affects, specifically, we see that pretty frequently in our sports medicine practice, that younger patients who have sports injuries will go on and develop some pretty significant degenerative changes. Like in this young man who's 29 years old, you see that there's diffuse cartilage loss and that there's meniscal tearing. And what Krishna has shown before, this bony remodeling, that means that this bone is overloaded, there's reactive change. So this is really, in this compartment, there's significant, at this young age, severe degenerative change. All right, so in the last part of my talk, I'm going to talk now about prevention and the lessons we've learned looking at large databases, trying to understand what's really best for the knee, what's best to prevent osteoarthritis, because the cartilage, once it's lost forever. It doesn't come back under normal circumstances. We need to protect it. And we're going to look at what we learned about prevention. Now, this is taken from the breast. This was one of our studies, which was published a couple of years ago, in which we showed that joint degeneration can be slowed with weight loss. We do know that obesity is a modifiable risk factor for osteoarthritis, and that weight loss and cartilage health are really directly associated. And this is some of the work we did. And we specifically used a very novel measurement of cartilage, which we obtained from magnetic resonance imaging. It's called T2 measurements, and they detect molecular changes of the cartilage matrix before cartilage is actually lost. So at a stage when the cartilage is still intact and there's no loss of it, it's potentially reversible at that time. So we can measure water content and we can measure collagen with this T2 measurement. And what we did in our studies, we looked at patients at baseline, and then we followed them up for 48 months. And we used the T2 relaxation time measurement as our biomarker, as our outcome measurement. Typically that increases, the T2 increases over time, like bone mineral density is lost over time, so the T2 decreases over time. And what we try to do is protect, basically prevent increase. This is showing the data we obtained. So we looked at obese patients without weight loss, and we looked at patients that had 5 to 10% weight loss over 4 years, and those that had more than 10% weight loss. And what we found was that the patients that had no weight loss and just remained obese for the entire study had pretty much the highest increase in T2 measurements, basically the highest increase in degeneration over time, while those that lost more than 10% of weight really did really well, and the cartilage T2 measurement basically didn't change at all over time. So that's a very good outcome. And while 5 to 10% weight loss also helped to reduce the progression of degenerative disease, the 10% was really that really impressive finding where we saw that the cartilage minimally degenerated. And this is illustrated in this image where you have nicely shown here at the baseline, relatively good cartilage quality with relatively low T2 values. The lower, the more blue they are, the lower they are. And then over time, these patients that were obese and didn't lose weight really had an increase in T2 measurements, that it's red now, it's in a higher range, while those that lost more than 10% weight actually did not change much over time. So a very good outcome for those patients that lost a lot of weight. And we saw the same also for pain, that those patients that lost more than 10% weight also seemed to be doing much better with their pain and had a decrease in pain scores, while the pain scores did not change in those that didn't lose any weight. 5 to 10% was helpful, but 10% really significantly improved the pain. So in conclusion, what we found in patients that were obese and overweight with risk factors or mild to moderate radiographic evidence for osteoarthritis we found that there is a protective aspect of weight loss. It's really important and extremely helpful. And specifically, if it's more than 10%, patients had significant benefit, not only in terms of improvement in cartilage quality or maintaining their cartilage quality, but also in terms of pain. And we think that if patients can lose this much weight, they can prevent progression of osteoarthritis and potentially also prevent end-stage osteoarthritis. Now, the other lesson we've learned was about exercise. So what we did, we looked at the effects of exercise on knee cartilage in middle-aged asymptomatic subjects with and without osteoarthritis risk factors. And we differentiated different activity levels. We looked at leisure, household, and occupational activities. And we differentiated 3 cohorts of patients. We looked at patients that were mostly sedentary, sitting most of the time. We looked at moderate exercisers and strenuous exercises. So how did this look like? When you look, so patients that were sedentary just watched TV most of the time, didn't really have much activity overall, while patients that were light to moderate exercisers had a lot of walking exercise and walked for more than 3 days per week, but less than 2 hours. Walking was really a key feature in these patients, that they tended to really walk a lot, but did not do any strenuous exercise such as running, basketball, cycling, tennis, or soccer. But keep in mind, these were all middle-aged patients that were mostly also overweight or obese. Now, what we found was that, again, the light to moderate exercises were doing really best. You see that, again, blue means good cartilage quality. On the left, you see that the sedentary patients didn't do so well. Their cartilage quality was not as good, and the strenuous exercises also did not do so well. So in summary, we found that patients that do mild to moderate exercise and specifically walking had overall healthier cartilage, and that both sedentary and strenuous sedentary people, and so those that did strenuous exercise, had more degenerated cartilage. But keep in mind, these were all middle-aged and older people that had risk factors for osteoarthritis. So this is really in line with the recommendations of the American Heart Association. So you're not only doing something good for your knees if you walk a lot, but you also do something good for your heart. And the sort of summary is really that if you walk 30 minutes a day, 5 times a week, that's an easy goal to remember. That really is not only good for your heart, it's also good for your joints. So finally, you may think, and this is lesson number 3, which is the best sport for you. And we also looked at this. We looked at different activities, including ball sports, bicycling, jogging, running, elliptical trainer, racket sports, and swimming. And we wanted to really see how people that are overweight, keep in mind, these were overweight and obese middle-aged patients with risk factors for osteoarthritis, how they were doing. And looked at this over 4 years, see how they did over 4 years. And what we found was that, in fact, that those patients that used the elliptical trainer actually had the best outcomes and had really least progression of degenerative changes, while those that did the played racket sports had the worst outcomes. So let me summarize. So what I've shown you over the last 15 minutes was basically that we use radiographs to diagnose osteoarthritis. So they're really useful to make an initial assessment of your joints. The MRI provides additional, more detailed information about cartilage, provides more detailed information because it directly visualizes the tissues and gives us more information. And then I think it's really important to keep in mind that once cartilage is lost, it's lost. You should also try to do everything to prevent osteoarthritis. And we know that weight loss is effective and moderate exercise is also helpful. So with this, I would acknowledge the funding we had for all these studies and I would like to thank you so much for attending this seminar. And I would once again like to thank Dr. Wolfsey and PG Handland for organizing this. I think this is a very important and important endeavor, and I hope you learned a lot. And I'm very much looking forward to discussing all the questions you have. With this, I'll stop share, and we're back again.
Great. Well, thank you both very much. It's a lot of information to cover succinctly, and you've done a wonderful job. And the questions that are flowing in reflect that people are interested. So I will just start. There's some that have been submitted during the talk. A few were submitted before the talk. So I'll just start at the top. The first one really relates to the stem cell issue that was raised. Given the limited amount of information on stem cells today, would you recommend or not trying this therapy? And I guess implicit in that question is, if you do recommend it, what type of patient should be thinking about that?
Yeah, I guess I'll take that question. That is a difficult question. It is so promising, and I do not know exactly who I would target this to be honest. And sadly, I don't think I can globally recommend this yet. I worry a little bit, like I hinted or said, that this is, as Thomas so beautifully sort of illustrated, it's such a debilitating condition that people are seeking something, especially in late stages. And I think that actually in late stages, it's not clear that the people who maybe want it the most might be the people for whom it's maybe the least effective. We don't know that yet, but just in terms of some of the animal models, it's not absolute sort of end stage traumatic joint animal models that people have used. So I think it's really tough if you're somebody who has a high grade of osteoarthritis and wants something to help, because it's, again, not standardized. The protocols are not uniform. It's not covered by insurance. So there's a lot of want and need, but the methodology is just not there yet, I think.
Great. All right, thank you. Well, the next question really be interested in hearing both of your opinions about this, but I'll start it off with Thomas since it relates to issues he spoke about near the end of his talk. Here's the question. What about weight loss if you are elderly but not overweight, but could lose 5 pounds or more to be college weight? How thin is still healthy? What's the best way to lose weight if you have arthritis? Is it calorie restriction? And I think, it's clear that what's being asked there is weight loss something that's only helpful to people at the extremes of obesity? Or is there evidence to suggest that it could be beneficial for most people or anyone? So Thomas, why don't you start out?
Yeah, so this is a very good question. Yeah, when we originally looked at this, we looked at patients overall and just looked at both normal weight and obese and overweight, obese, and normal weight patients. And what we found was that all through most of the patients really profited from weight loss. I mean, we don't want people who are normal weight really to lose more weight. We don't want them. But overall, if patients are overweight, and a lot of us are overweight, unfortunately, it makes sense and it really helps. And so that's definitely something which is important. But you had the second part of the question. What was that again?
Well, I think you really addressed it, but there was a second part of the question that had to do with what's the best way to lose weight? Is it simply calorie restriction?
Yeah, we looked at, we had, this was a big study where we looked at thousands of patients basically, and we gave them a questionnaire and we looked at, was it related to diet? Was it related to exercise? Or was it related to both? And what we found was that those patients that did the diet profited most. And we found that those patients that only tried to lose weight through exercise actually didn't do so well. Their quality of cartilage did degrade more than those that adhere to diets. So I think overall, I think that diet is more effective than exercise. Probably a mix of both is good, but it should not be really extreme exercise because that's also not helpful. But the diet part is the most important one, according to the studies we did.
And so I might add to that a question that hasn't come from the audience yet, but I'm guessing is on many people's minds because it often is when we see patients. Are there any foods, any diets that are helpful to people with osteoarthritis? And I don't mean now in terms of weight loss. I mean in terms of medical benefit, analgesia, whatever, anti-inflammatory. Are there any dietary practices that you would recommend to someone who has osteoarthritis?
Yeah, I can speak to this a little bit. So there hasn't been, at the level of strong evidence, a diet that really has been shown to slow down the progression of osteoarthritis or prevent it. There is a lot of interest in sort of an anti-inflammatory diet or a Mediterranean diet that's high in certain nutrients. But when you look at things that sort of have been studied with some rigor, there are these components of an anti-inflammatory diet. For example, things like turmeric have been studied with reasonable, sorts of studies. And some of that is done through places like the Osher Center, which is another really good resource I just want to plug for patients who have some of these kinds of questions that suggest that it can be very helpful as an analgesic. But I'm not aware of anything that has been shown in a strong way to affect structure. I don't know if Thomas, you have thoughts.
Okay, well, let's move on. Here's a question asking about the relationship between osteopenia and osteoporosis and the development of osteoarthritis. Is there any relationship is the question, and what would be the role of any supplements in improving collagen, for example, D3? And in answering it, you might first make the distinction between osteopenia, osteoporosis, and osteoarthritis for those people in the audience who may not know the fine distinctions between those terms.
You want to take this one, Thomas?
Yeah. So I'll be happy to address that. So so basically osteopenia and osteoporosis is bone loss. And a standard measurement tool to measure bone loss is dual energy X-ray absorptiometry, that's DEXA. And we differentiate different types or degrees of bone loss. So osteopenia is if you have less than 1.1 to minus 2.4 standard deviations below the standard compared to a young normal reference population. That sounds very complicated now, but I think the difference between osteopenia and osteoporosis is just the degree of bone loss. A lot of patients that are older do have osteopenia, but the treatment is usually initiated if the patients have osteoporosis, and that means they have 2.5, their bone mineral density is 2.5 standard deviations below that of a normal young reference population. So that's when usually the treatment is initiated. And there are other methods also to determine fracture risk, such as the FRAX score, but I don't want to go into much detail here.
I think in the context of this presentation, they're also asking, is there a relationship between bone loss and the development of osteoarthritis? In other words, people with osteoporosis, are they more or less likely to get osteoarthritis? Does it matter?
Yeah, I'm sorry, Thomas. I was going to say that locally, people actually get an increase in their bone mineral density in areas of osteoarthritis. So it's actually a little bit of an inverse relationship, if anything. Although globally, it's very important to have healthy bones to be able to exercise and not get fragility fractures or stress fractures when you're trying to do the walking that's recommended as well. So they're both important, but they're not linked in that particular way.
What we see in the spine is that, interestingly, patients that have osteoporosis tend to have preserved discs, and those that have very dense bones have more degeneration of the discs of the spine. But yeah, I'm not entirely sure how this would be. It's generally, as Krishna is saying, that very dense bones and strong bones tend to degenerate the cartilage somewhat quicker. But on the other hand, osteoporosis also causes fractures, and that has all kinds of other complications. So you don't want to have soft bones, because then you have a lot of other problems to deal with.
And here's another question from someone obviously sophisticated in the technology. Any bone marrow, are bone marrow lesions and changes in composition of cartilage related? For example, T2 scores related? Is there a correlation between these measurements?
Yeah, that's a very good question. So what we see is that as the cartilage degenerates, the bone is not as protected anymore, and then the bone remodels, and then we see these bone marrow abnormalities, these bone marrow lesions, how our rheumatologists call them. And so that is usually a sign of cartilage degeneration. So they are related. So as the disease, the degenerative changes progress, you see at the same time, you see cartilage increase in T2 values, you see cartilage defects, but you also see bone marrow changes. So they are interrelated.
And here's someone else who was, I think, prompted by your responses on osteoporosis, asking a related question. Are there other treatments for osteoporosis? This person also has osteoarthritis besides Fosamax.
Oh, yes. So, I mean, good bone is sort of always being taken away and always being formed. So there are two arms to that. One is medicines like Fosamax that help stop the taking away or resorption of bone. And there are other medicines on that side of the equation. There's something called Prolia or denosumab that can be used if a particular patient isn't responding as strongly as we would want to the Fosamax. And then for more extreme cases or in specific instances on the other side of the equation, you can directly build bones. You're not inhibiting its being taken away, but you're actually making it happen. And there are a few other medicines that do that, and there are one or two that kind of do both. So there's a lot of different options depending on the patient.
Great. We also have a couple of very interesting questions that relate to people's own individual situation, but I think probably are not unique at all. Here's one. I am a 78-year-old woman who has already had both hips replaced and will soon need knees. I was not an athlete, had no serious injuries to explain my bad joints. My daughters are worried that they will have the same problems. Does this kind of arthritis run in families? And if so, is there anything they can do to protect themselves? And I suppose implicit in that is also, why did I get this? I did everything right.
Yeah, that's a very tough situation. The genetics of osteoarthritis, there are some large studies looking at genetics, but part of the issue with those is that there are so many different subtypes to OA, and some of these studies are very broad. So there isn't certainly a single gene mutation that we can usually point to. There are sometimes underlying conditions that predispose people to OA in more diffuse joints than one would expect, or earlier than one would expect. And that's probably where it's worth sort of sussing it out with somebody like a rheumatologist or somebody who's thoughtful about this. If there's something hereditary, either if it's bilateral hips and there's a history of that, then is there some anatomic issue with dysplasias in the hips? Or sometimes people who have a condition called hypermobility are more prone to osteoarthritis early on because they have laxity of the periarticular structures that leads to some repetitive micro trauma. And certainly autoimmune arthritic conditions can sometimes be missed and can cause earlier or more diffuse osteoarthritis that's really secondary. So I think it's sort of very individual, but it might be worth meeting with somebody to see, just so your kids are reassured somewhat.
Great, very helpful. All right, here's one more. If you were to look at my hands, you would say that I have severe osteoarthritis. My friends all ask me if it is very painful, but the truth is it hardly bothers me at all. Can I expect things to get worse? And should I be doing anything about it?
Yeah, it's hard to say without meeting the person, but I think there are different types of hand osteoarthritis, and Thomas certainly knows this from X-rays as well. But the more common spots that get into trouble with pain are the wear and tear joints that are vulnerable. So the base of the thumb is a big one. But then there are other kinds of patterns that affect, mostly, for example, the tip top joints here and the middle joints that are not the knuckle. And sometimes people get very different looking hands. They're sort of zigzagging with big, bumpy, bony, growths. And it's not terribly painful and it's not terribly debilitating. So there are different, I think the broadest answer is to say there are different varieties of hand osteoarthritis that change the way they look and how they feel.
So if I understand you correctly, you're saying it's not that unusual for there to be a disconnect between the deformity and the pain, the degree of pain.
Yeah, that's right. And actually, again, Thomas can speak to this, but that happens even in large joints that are not the hand, that early on people have a disconnect where the radiograph looks different than how they're feeling.
Yeah, we did a number of studies where we looked specifically at the degree of radiographic osteoarthritis and deformity. And we were really impressed by the disconnect, as you were saying, Krishna, that a lot of patients, some of them had really advanced osteoarthritis in the radiographs, but had very limited symptoms and had very limited pain. And then we had these patients that had very early findings and had significant amount of pain. We also looked at joint replacement. And it was very interesting to see that a lot of patients actually at relatively early radiographic stages had already joint replacement because the joints were so symptomatic, while some patients that had really advanced disease just did not want to have joint replacements. It's quite intriguing how the morphologic findings, the deformity of the hands is not perfectly aligned with the symptoms.
Here's a question that just came in that's a very appropriate follow-up to that discussion of the last question. How do you know if osteoarthritis has progressed enough for knee or hip replacement? Always pain?
Yeah, it's a tough question and very individual. I think that the key is that there hasn't been shown one particular radiographic sort of stage or finding that suggests that you definitely should go. It's a very qualitative, quality of life decision. So what I usually tell patients is to sort of look at where their functionality is in the present moment compared to, say, a year ago or 2 years ago, and how much more circumscribed do they feel that their activity level has been. And I think that as Thomas was sort of implying, there'll be different ranges of the way that imaging can look. So there's no one test to say it's time. It's a conversation and a shared decision with the surgeon.
Looks like we may be able to get everybody's questions answered. So here's what might be the last one, unless more come in. And we're right on the hour, so that's pretty good. My teenage daughter tore her ACL playing soccer in high school. She has completed rehab and now wants to play in college. I'm worried that she will pay a high price for these youthful injuries in the form of disability later in life. What is the long-term prognosis for young women with serious athletic injuries? Certainly Thomas pointed out in his presentation that you definitely see this in young people, especially in athletes. So if you could address prognosis and maybe when you would say enough is enough is sort of the implication of the question.
Yeah, do you want to go or should I?
Go ahead, I can chime in.
We did a number of studies with patients that had ACL tears, and we looked at them over several years, and we found that those patients that have ACL tears, even if the ACL is reconstructed really nicely, and they still progress more frequently and significantly compared to healthy knees. And we compared it side by side and saw the progression of the diseased knee. So we know that patients that have ACL reconstruction will have a higher risk to progress to osteoarthritis. And we do see that pretty frequently. And Soccer is one of these sports which does stress the knee significantly. And I think what's really, I mean, unfortunately, we see these young patients, and I've shown one of these in my talk, that have these really destroyed knees. And keep in mind that also total joint replacements only have a limited lifespan. And if you have an end-stage knee at the age of 40, then that's bad news, because that's probably not the last joint replacement you will need. So I generally would caution her after an ACL reconstruction to really play aggressively sports again. I think that is potentially a dangerous thing. But it depends also on the joint, and it depends on how well it's done. And probably if it's regularly monitored, then it would be good to see, okay, is the cartilage now breaking down, or is it not breaking down? Is the cartilage staying healthy or not? But in my opinion, that should really be followed up with magnetic resonance imaging. If the cartilage breaks down and it's obvious after 1 or 2 years, then I think the recommendations should be much more strict in terms of sports, especially with soccer, because soccer is not healthy for a diseased knee.
All right, well, thank you. I'm going to see if I can share my screen for one final slide. Let's see. That's not there. I think I am. So really the purpose of this slide is to acknowledge that this program is supported by the Russell Engelman Rheumatology Research Center and the Division of Rheumatology at UCSF. I certainly want to thank them. And of course, Dr. Shagante and Link, who were really wonderful. And as well, thanks to everyone who attended. I hope you found this session informative. You'll hear from us again when the topics and schedule for future programs have been finalized. If you're interested in learning more about our programs or offering your support, which we'd much appreciate, here are the links to the Division of Rheumatology and the Russell Engelman Center. I should add, especially for those who may have joined late, that I mentioned at the beginning that this program was being recorded, and it will be posted on YouTube within the next few days. So I hope that you will feel free to mention the program to friends and family who may not have been able to participate tonight. And with that, everybody have a nice evening, and thank you again for attending.